Recording in progress.
Good afternoon, Lois. Good afternoon, Ivan. Good afternoon, Angela Davidson.
Good afternoon, Elizabeth.
Yes, thank you
Afternoon,
for
Doctor.
joining. Yeah, good afternoon. We are just going to give people a few more minutes to join. So happy you've been able to join. Our panelists, Lois and Ivan, thank you so much for joining us. I think everything is set. If there are any issues, you can just send me a message on the chat. But since we've talked before, I think everything is fine. We'll just give people a few minutes to join, and then we can start off. Noel, are you ready?
I have no rights to design a poll in the system. I have to be the host.
Davidson, are we able to sort that out, like in 1 minute or something?
Noel is a co-host.
I think he said he needs to be the host for him to do that. Lawrence, could you please? We want to welcome you for this seminar. You're very welcome. We are giving our participants a few more minutes to be able to join us. Before that, we would like to do a short poll. Just possible. Noel, could you let me know if you think that will be possible?
Davidson, could you make me a host and I see if we can design them very fast?
You now the host, so we expect that in 1-2 minutes we'll see those questions popping up. So participants, you're very welcome. Now, this is a hot topic for all of us because we all need to keep safe. We want to get to know a little bit more about what's happening to you as we begin. So we want to find out, have you had courage to take a COVID test? Some of us have had the courage, some of us in a minute, just for us to get a feel of what's going on the other side. So those questions should be popping up any moment. Thank you so much for making it to this session. So we expect the session to run for about 1.5 hours. We shall try our best to stick to that time. We are going to be requesting that you put your questions in the chat and start sharing them as early as they come up so that we can be able to answer them. Noel, you can just put whatever you have ready, even if it's 1 or 2, because we are starting off minute.
We won't be able to have the poll.
That happened or not?
We may not be able to have the polls.
Okay, that
I have to log in Haditha's account. Yes, we will not be able to log in.
okay. That is fine. So good afternoon, everyone. My name's Elizabeth Ekirapa Kiracho. I'm a public health specialist with expertise in health systems and health economics. I work at Makerere University Public Health. We are particularly apologize for the background noise. Davidson, perhaps you could take over from being host from now so that you can control it. Participants are requesting that you mute. Let's take a minute to mute. Thank you. That's a lot better. So I had just introduced myself. I'm pleased to be with you again. We held this seminar last week, but because a number of people were not able to attend, and people kept trying to get into the seminar, even although we have decided to repeat the seminar. So the main point of this seminar is just to require. We know that according to our current strategy and case management, those who don't have severe illness are being looked after at home. But while we for our patients at home, we know that we have also got reports of people who get to hospital too late, and we lose them primarily because they don't get appropriate care as early as to get it. So we are able to monitor them. We know exactly when we need from the healthcare workers. So we want to give you some of the best will be harmful. So we want to just touch and discuss some of those issues and ensure that we are managing this as well as we can. I hope I will not have those internet hassles again. I hope I'm back. Okay, so this afternoon, I was saying we are previous with us. Are you hearing me clearly?
Yes, doctor.
Yes, we can hear you.
Okay. Thank you. So this afternoon, we are privileged to have 3 presenters with us. The first panelist we are going to have is Mrs. Lois Kyoma, core consult. Lois got COVID sometime back. She managed it at home, and so we thought it would be important for her to share some of her experiences so that we can be able to learn from it. So Lois, you're very welcome. Thank you for making time to be with us. We shall also okay, thank you. So we shall also be joined by Professor Pauline Biachika and Dr. Bruce Kirenga, but there's a COVID-19 meeting that is going on right now, and they were both called to that meeting. So able to attend. Dr. Bruce may or may not be able to attend. So we shall be joined by Dr. Ivan Kimuli, and I'll be introducing. So we are going to start off by having listening to a few experiences from Lois, and then after that we shall move on to hear from Dr. Ivan, and then you'll have an opportunity to ask your questions. Like I said, if you have any questions, please do put them in the chat, which I'll be happy to respond to them. We expect to be able to conclude the session by about 2:30. If you have questions, please put them in the chat. So I'd like to move right away to having a discussion with Lois. Lois, requesting that you put your camera on. So thank you, Lois, once again for joining us. I'll give you an opportunity to just say hi to us.
Thank you, Liz, for having me. Hello, everyone. I'm Lois Kyoma, as she said before, and I'm just here to share my experiences.
Okay, thank you. You're looking great. So we are reassured that if we have COVID, we are not going to get all battered by the end of it. So I wanted us to begin by just, finding out briefly, how did you actually get to know, this is the dreaded COVID-19? Could you just walk us through that a little?
I got to know, I did a test, the antigen test. But before that, I didn't have any suspicion because I thought I was being careful. And I didn't present with any of the classic symptoms. I had no fevers, I had no sore throat, I had no cough, I was fine. The only thing was I had some muscle ache in my lower limbs, and I had recently started exercising. So I thought, it's just my muscles getting used to more exertion, but it didn't go for about a week. So I decided to test. Actually, I didn't decide to test, but one of my sons started complaining about having headaches. So since he was complaining, I decided that the two of us would go and have the tests done. I didn't think they would come back positive, but unfortunately, they did.
Okay. So after they turned out positive, what did you do next? Where did you go for care? Why did you choose these facilities? There are so many facilities one could go to. Did one facility meet your needs? Did you have to go to 2 or 3?
So before I did the test, there's someone who needs to meet.
Then if you can mute. Okay, thank you. Sorry about that.
Okay, so before we did the test, I'd had.
Lois, you're unmuted. You're muted, Lois.
You seem to have muted yourself somehow.
Okay, before we did the test.
You've muted yourself.
Am I? No, I'm not muted anymore. Before we did the test, I had stories about, because patients were having to meet with COVID. So the first thing we did was call my medical insurance, the people who offer me medical insurance, and ask how much or whether they cover us. And the person I talked to told me that they would cover the tests and outpatient and inpatient to a certain limit, and then recommended the facilities I could visit. So I took his advice. He told me to go to Victoria UMC. So that's where I went, based on his advice. And doing the tests was pretty easy. After that, the doc who interpreted the results for us was the one who gave us the initial treatment. The only thing that I found a bit challenging was the fact that we arrived at 9 a.m. and left at 5:30 p.m. So, for example, I was with a child and he was grumbling the entire time. But besides that, I think the doctor handled us quite well. He was concerned about, while my child was positive, he seemed okay, but the doctor kept on talking about how my CRP levels were too high, and I needed to be careful. So he gave me treatment to go home and come back a few days later to check again. So a few days later, I was back and had the same experience, 9 a.m. to 5:30 p.m. So I decided to switch. And at that moment, I decided next time I will not be coming here. I'll just pick everything, all my information, and go to another facility. So I visited 2 facilities during my illness. That was Kampala Hospital and UMC Victoria. And I found that at Kampala Hospital, it was faster. They attended to us faster than they were attending to us at Victoria. So I settled with them for the other hospital visits.
Okay. So in your experience of care, did you feel that the facilities were able to provide you all the kind of attention that you needed? Were you generally satisfied that there are areas you felt, well, this wasn't handled too well?
I think overall I was satisfied with the hospital treatment. The nurses that dealt with me were at first, the second time I went in, I was a bit afraid. And I told this nurse who was doing the triage, I told her, she was very reassuring. She told me, you don't have to worry about it. People get this. Because I kept thinking, I could give this person this and this person will hate me, yeah? And she was like, don't worry about it. So she made it easy for me to go in the next time I had to visit other facilities. And overall, I found they were compassionate, the people, whatever was going on, and explained. So yes, I was satisfied.
Okay. Then I also wanted to find out, there is a lot of negative social media that we get. When you log WhatsApp, you hear.
Sorry, I didn't get that.
That's why I paused. Okay, so I was saying that there's a lot of negative social media. All the time you hear so and so has passed on, so and so is ill, and so on and so forth. So how did you cope with that kind of negative social media? Did you get worried? Children get worried at some point? How did you handle those psychosocial issues of this illness?
The one thing I could say was while I was at home, I was having a really hard time. So phone calls or messages that were coming in would bother me. So I put the phone aside. But I would say, so I didn't really get to know about people who were lost during the time I was dealing with this. I only heard about them after. So that didn't affect me. But sometimes I would be able to check my messages late in the night when it wasn't so busy and have discussions. The only time I got afraid, it wasn't to deal with death, was I was looking at my phone and I was trying to read what had been sent to me and I couldn't make heads or tails of it. The words, I was just looking at the words and they didn't seem to make any meaning to me. So I remember picking a novel that was at my bedside just to check and see if it was an issue with the phone screen. And I could not read what was in the novel. So I asked my hubby to give me a newspaper because we were isolating together and I still could not read. So that was the one time I remember actually getting scared, wondering what on earth is this disease doing to me. But in terms of not making it, no, the thought never crossed my mind. Right from the time I got the results, I knew I would beat this. In fact, the people who seemed to be fasting were the people around me, but I was not scared about the eventual outcome. I felt I could make it.
Okay. Did your children seem to be scared?
Yes, the news wasn't broken to them in a nice way. Because I have 3 kids. The oldest is the one who had tested positive. And when we got home, he walked ahead of me into the house. And he stood at the door and just shouted at them, "Mommy has COVID-19, she's going to die." So I came in behind him and the other 2 were looking wide-eyed at me, you know, and they moved back because they come to greet us. So they moved back into the house and, you know, they kept staring at me like I was at death's door. So it took a lot of reassuring from my dad that, you know, it was just like having a bacterial infection, I would fight it. But until I was able to come out of my room from isolation and see that I was no longer suffering, they were afraid and they kept asking what's happening. And every time we went to the hospital, when we'd get back, you'd see them staring at me like they thought I was at death's door. However, they seem to have recovered nicely now.
Okay. Okay, thank you. So as we be dealing with COVID, what would be your quick advice?
My advice to anyone who might have it would be not to panic, because when you panic, there's so many things you could do that could go wrong. The other thing is, I would advise anyone and everyone, once you've got it, to seek professional help, because there's so many people are sending around all kinds of remedies and treatments, and people are deciding to self-treat. So, for example, somebody says you can have azithromycin and ivermectin, Dexter, and people do not know about the doses they need to take. While a professional will be able to factor in some of your biodata, I think, before they recommend what you should. So before we deal with the self-treatment and all the remedies being sent around, I would advise everyone to seek help from a professional medical person.
Okay. Okay, so thank you so much, Lois. I think we'll close it there. Some people may have some, questions for you at the end of the session. We request you to please stay with us. Thank you for sharing your experiences, giving us those tips. I think we've learned some things already from that. So I'm going to quickly move on to Dr. Ivan Kimuli. When I was asking Dr. Ivan about himself, he told me he's a simple Ugandan. So I'll begin by saying Dr. Ivan is a simple Ugandan. He is a physician working with Makerere University. He is part of the national case management team that is helping us come up with protocols, give guidance on how we should manage this illness. So Dr. Ivan is going to be sharing with us mainly some of the things that we need to know as lay people. We want to still related things, but we want to focus a lot on home-based care and just some issues that are important for each one of us to know. So Dr. Ivan, thank you so much for sparing time and for joining us. If you have questions, please do put them in the chat. James, I can see your hand. Please put your question in the chat, and we'll be taking questions later. And please do mute so that we don't have interruption. So Dr. Ivan, you're very welcome. So we'll have Dr. Ivan for the next 30 minutes, and then we'll move on to answer the questions that you have. So over to you, Ivan.
Thank you very much, Dr. Ekirapa. I hope everybody can hear me.
Yes, we hear you loud and clear.
I'm going to turn on my video briefly, just for people to see my face. And thereafter, I may, I'll turn it off. Okay, that is the face behind the voice that you're going to be hearing for the next 20-30 minutes. So thank you very much. So today we are going to talk about home-based care in relation to COVID-19. There are so many home-based care models for other conditions, but this one is specific for our condition that we are interested in. So as a way of background, everybody by now, even a 3-year-old, will talk about COVID-19. But this is an infection that is caused by a virus called severe acute respiratory syndrome, named SARS-CoV-2. The disease is COVID-19. And what are the different modes of transmission? We have respiratory droplets, people coughing and leaving some droplets in the air, contact with contaminated objects or surfaces. And when you have your hands touching these contaminated surfaces, you raise your hands to your eyes, touch your eyes, you may infect yourself through the surfaces of the eyes, especially the one that has that is really covering the thin film that is covering the eyes. Then indoor settings with inadequate ventilation, of course, offer you a high chance of being infected potentially. So if you stay in a small house with many people and then you have a patient in there who's coughing, generating aerosols, this place doesn't have windows or large openings, definitely you're going to have the risk increased. So what are the routes of entry? I keep telling people that if we could just stop our respiratory system from accessing any infected area, we shall be protected from COVID-19. So it is the upper respiratory tract or the facial mucosa. This facial mucosa, we are basically referring to the mucosa of the eyes, the lining of the eyes that produces the tears, that has the tear film, because this has access to your respiratory tract, and therefore it ends up having access to the receptors, which are the SCE2 receptors, on which the virus is going to bind and subsequently find itself inside the body. The incubation period refers to that time between exposure to the virus and the time that symptoms can be picked in a patient, or the patient can feel symptoms. So this incubation period is on average 5 to 6 days, but varies from 2 to 14 days. So what are the common symptoms that we see? You remember in the beginning, many symptoms many people used to talk about the flu, the cough, but as you may realize, some of these things have actually been different in some patients. So a fever, a dry cough, myalgia refers to pains in the muscles, or fatigue, shortness of breath, a sore throat and a headache, and others include flu-like symptoms, diarrhea, nausea, loss of smell and taste, muscle aches, difficulty in breathing. This is really scientific DIC. So we tend to see a lot of fevers. We tend to see a lot of headaches. We tend to see a lot of dry coughs. We tend to see a lot of weakness. Loss of taste and smell have categorically been classified as probable symptoms. So when you have these two, you actually, or any of these two, in the absence of anything else that can explain your loss of smell or taste, you are categorized as a probable case of COVID-19. So as you may see, the symptoms are really varied. They can happen in literally all the systems. In the head, we see that you can get the central nervous system giving you a headache, a sore throat. Chest, you have difficulty in breathing, the dry coughs in there. In the abdomen, you have your nausea, vomiting, and then the other symptoms that just occur, muscle aches, which really are generalized, muscle pains, fevers, and chills. So with these symptoms, we can actually categorize a patient as to whether they have asymptomatic or pre-symptomatic disease. And then we have the mild illness, the moderate illness, the severe illness, and the critical illness. as you may well appreciate what what Lois presented, she got a positive COVID test with some mild symptoms. And I guess this is one of the reasons that she initially was at home. So asymptomatic, you could only have your test positive, but you literally have no symptom. I mean, I think the majority of us have actually been asymptomatic. Some of us have tested, some of us have not tested. But if you just did a random survey, especially at a time when the peaks were high, or when the waves were at their peaks, there are very many people who could have been asymptomatic, but having positive tests. Now, the mild disease really is varied symptoms. You have a low-grade fever, you have a cough, you have a sore throat, you're feeling weak, headaches, muscle aches, but you don't have signs sufficient enough for us to say that you have a pneumonia. You don't have shortness of breath. You don't have abnormal imaging. If we are to perform an imaging test or study of your lungs are going to be normal. So you don't have anything that can show to us either clinically or through investigations that you actually have a pneumonia. So that is mild disease. And with the home-based care, we restrict ourselves to the management of patients that are either asymptomatic or that have mild disease at home. So all the other severity categories that you're seeing below mild are not supposed to be managed at home. If your pulse, your oxygen concentration in the body is above 90, but you have evidence of pneumonia, you have moderate disease. So you and anyone below that is not supposed to be under home-based care. Majority of people, fortunately, are going to have mild illness. So that's why you see that in our strategy, we moved away from admitting and hospitalizing everybody to saying that since we now have community-based transmission, we can actually manage some patients at home. Initially, when we had sporadic cases, when we had patients just coming in, a few clusters, we could afford to manage patients, all of them in the hospital. But when you manage everybody during community transmission in the hospital, the healthcare system is definitely going to be overrun. But it's important to note that majority of us are going to be mild disease and so can be managed at home. So the home-based care model in Uganda and elsewhere is ideally based on strong linkages between the home, the community, and the health facility. So there should be a collaboration between all these partners in order to deliver holistic, integrated, and continuous care. Where does home-based care start? You cannot say you're under home-based care without a test that has actually confirmed that you have COVID-19. This is one of the elements that we have seen challenging us, that some people have actually had symptoms and they stay home and they think they actually have a feeling that they have COVID-19, but they don't test. In that way, when you do not know where you fall, you may fall short on some of the interventions that are supposed to be given to you at home. We've seen many people, because they were in contact with the patient, they start off with azithromycin and all these other drugs. But let us start with a test. If our test is positive and it is done at a facility, then this facility is the one that is responsible for assigning you the home-based care status. For you to be at home, it's important that the healthcare worker is the one that has actually assessed you and found you to be eligible for home-based care. We appreciate that we have so many people that are reading a lot of information around COVID-19, but there may be those subtle things that you may miss as the patient if you have not been evaluated by someone else. So only the asymptomatic cases and cases with mild disease are the ones that we care for at home. So the decision to isolate is made on a case-by-case basis. And what are we looking at? we are looking at a couple of parameters. One is your clinical presentation. Are you mild? Are you asymptomatic? Could you be pre-symptomatic? But the other thing is, do you have risk factors that could potentially put you in a position with a severe disease form? So if you're elderly, and I'm sorry to say elderly, I know 65 years is not very old, but I think for our situation, 65 is fair enough. Patients who are obese, patients who have underlying conditions, the non-communicable diseases that we've been talking about, cardiovascular disease, diabetes mellitus. Does someone have chronic lung disease? Do they have, let's say, COPD and things like that? Do you have a chronic kidney disease? Are you immunosuppressed, either on continuous medication that is suppressing your immunity, or you have HIV or any other underlying immune suppressive condition? And cancer, whether the cancer is on treatment or not, you are one of the risk groups that could potentially get severe disease if you got COVID-19. But beyond the clinical presentation and the severity assessment, the risk assessment, we also look at the state of the housing of the patient. Clearly, if you have one room, which is a 20 square meter room, and you're staying probably 6-7 people in there, the beds are just close together, people are sharing beds, maybe your home is not exactly what is appropriate for the home-based care model. Maybe you need to be put in a setting where you can be taken care of without putting other people at risk. And then as we send you home, we need to establish that there is a healthy adult caregiver. We should have someone who's going to take care of you. This is an adult, and this person should not be more than 65 years of age, should not be obese. What am I saying? That person should not have the risk factors above that we are talking about that could potentially put him at risk of severe disease if they were to get infected. So the clinical evaluation, the evaluation of the home setting, then ability to monitor the patient at home. So the clinical evaluation we've looked at extensively. Evaluation of the home setting, we've talked about the infrastructure, how much exposure is there? Is it likely to be if we left you home and getting other contacts that are definitely going to turn out to be high-risk contacts? Then IPC measures. What are the potential breaches in IPC that could occur if we let you home? Do you have water, running water or clean water? Do you have access to this? Do you have access to soap? Do you have access to simple things that are going to kill the virus when you're cleaning your utensils, washing your clothes, cleaning your environment? If some of these are unlikely to be available, then you are putting other people at home at risk. So maybe these are people who shouldn't be home. And the basic support standards. Do we have food? Do we have access to food? You know that in CTUs, we actually give patients who are admitted food. This is because we know that some people can actually not support themselves, but also we don't allow attendance there. So we need to provide all these basic standards, water, food, and everything that the patient would need in there. The ability to monitor a patient, clinical evolution of symptoms when the patient's at home is key. If someone is going to stay in their home and they're alone, they convince you that they are going to take care of their pulse, they are going to take care of their oxygen, they're going to take care of their fevers. It is possible, but if the tide was to turn, they may not be able to communicate with anybody. So it's important to have this system clearly stipulated at home that if evacuation was needed, if somebody was around to identify progression of disease, evacuation can actually occur in a timely manner. These are the different standards that we look for. You should have a functioning telephone that can ably reach out to a healthcare worker or someone that may help you be evacuated. Separate rooms if available, but if the separate rooms are not available, we encourage that in the room in which you're staying with another person who's not infected, this room should have at least 2 meters between the beds if you're staying in a single room. The patient's bed should be at least 2 meters away. And we recommend that the persons that are not infected should only go in and spend very little time in there if indeed the patient is being isolated within that room. And if possible, you should go in for sleep. When you're going in, you make sure that you have your mask. When you're going in, you make sure that after when you're getting out, you sanitize or wash your hands, and make sure you keep the time that you're in that room as minimal as possible. The room should have adequate air ventilation and flow. You should have accessible bathroom and a latrine or a toilet. What resources should be available? Food should be available, medications should be available, masks. If someone is going to be home and they cannot access masks, then it is better that this person is actually admitted. When you are under home-based care, you and all the people at home that you're going to get exposed to are ideally supposed to be masking. So masks should be available for that home. If only one person is going to be masked and the others are not, probably that's not the best place to keep information. IPC supplies, we already discussed that, dedicated caregiver, and arrangements for evacuation. There should be a clear system that in the event that the patient's condition worsens, the evacuation process can actually be simplified. We shouldn't get patients presenting late simply because they struggled with the evacuation. So who should not be considered for home-based care? The categories that we talked about are on your right. People who have high risk of severe COVID-19 should not be accorded home-based care status. Older adults, people with cardiovascular conditions, diabetics, children with underlying comorbidities, sickle cell, cancer, and the list goes on, pregnant women and smokers. Now, when we go to the clinical presentation, anyone that presents with danger signs, even if they do not fall under the category of high-risk disease, should not be accorded home-based care status. So patients with danger signs, in terms of respiration, you can tell anyone above 30 breaths per minute for a child or for a child above 5 years or one adult, and this goes on and on and on. Patients are present with difficulty in breathing, persistently high fever, patients who are disoriented, anybody who's extremely weak, tired, people with seizures, convulsions, and people who are unable to eat or drink. I have seen patients that have insisted, or their relatives have insisted on keeping these patients at home. But these are patients that are likely to fail under home-based care, and we shall struggle with evacuation. So if you assess a patient and this is how they are presented, please let's not send these patients back home. These groups we've mentioned, and when we are home, the implementation, the home-based care module or model builds on existing health systems that are available in the community. Now, this may not exactly apply to all the homes or all the stakeholders. For example, in Kampala, the model of VHTs and non-formal caregivers, like volunteers who are coming from health facilities, may not necessarily apply. For example, how do you find a VHT moving between Muyenga and Kololo, looking for patients who are in their homes, they are coming in to give care? It's unlikely to be the case. Maybe these are homes that are going to utilize a health professional from a health facility that is going to be checking on them on a daily basis, either physically or telephonically in a safe way. So we have these existing community levels, health professionals, VHTs, volunteers, but you can have a family member. And majority of the home-based care providers are actually family members, as long as they've been told what to do, how to identify a patient that is likely to be worsening, and then they link this patient up to the health facility. So these healthcare providers are going to operate at different levels, and these may not be exhaustive, but the different levels all need to be clearly linked. So your family member provider should be able to know a phone number of a health professional that they can call. The health professional should be able to have an idea of which mechanism to activate so that you can be properly assessed and safely evacuated into a health facility. So for every positive individual, the individual must be supported, linked to care when the tests are back at the dispatch center. There must be a triage desk that is going to help assess this patient, okay? A VHT member should be identified. And like I said, this does not necessarily work for everybody, but for the broader system, for the broader country, I think majority of our family members may work closely with the VHT that has been identified by the healthcare facility and introduce this patient into home-based care. So that VHT is supposed to check on you on a regular basis, while you also at home are monitoring yourself together with the family member that is monitoring you. We do have monitoring tools that are given to a patient that has been accorded home-based care. And these monitoring tools are looking at how fast you're breathing today, what your temperature is like today, is your cough getting better, is it still on, is it done? And so you keep ticking for the time that you're going to be isolated, which is usually 10 to 14 days. So the patient and caretaker have roles, just like different stakeholders. They have roles that they play while you're home. The patient and the stakeholder should know, and the caretaker should know and get the telephone contact of the VHT or the community health worker or the local council or the health assistant or any healthcare worker. So every home-based care patient should have a contact of a healthcare worker that can activate an evacuation system or an evacuation process. Then we perform daily monitoring and recording of new symptoms or danger signs. If today you are fine, but in the morning you wake up with a respiratory rate of 35, then this is a danger sign. And this should be recorded, and you inform the VHT or whoever the person is that is supposed to evacuate you or supposed to do follow you up. The Ministry of Health set up a USSD code to generate alerts in areas where mHealth platforms with automated regular daily calls exist. So when you dial, when you're a patient that has been given a unique identifier for home-based care, this is what you dial, and then on the receiving end will be somebody that is going to attend to you. And in the event that they assess that you actually require evacuation, this mechanism is going to be activated. So the emergency warning signs, when do you think you should evacuate a patient? If a patient has persistent pain or pressure in the chest, they may not necessarily say pain, but they feel something that is putting a lot of pressure in the chest. If someone is having trouble breathing, somebody that was not confused has developed confusion, inability to wake or stay awake. We know COVID-19 causes a lot of weakness, fatigue, extreme fatigue. Well, many of the patients that have suffered COVID, they'll tell you that. If a patient turns pale, they are gray, blue-colored skin, this may suggest that their oxygen levels are falling, that this is really advanced. The nail beds turning blue, depending on the tone of the skin, the skin may also turn. But if they also develop convulsions, inability to eat or inability to feed, that is feeding, eating and drinking, this is a patient that needs to be evacuated. So as a member who's taking care of this person at home, please. So the signs that are going to show you, this is just in one symptom, in one system, the signs that are going to show you that someone is developing distress, be it an adult or child, really relates to the breathing, inability to talk or walk unaided, confusion, use of accessory muscles. If someone is breathing and you realize that they're actually lifting their chest up so much, or their neck muscles are becoming prominent as they inspire, as they clean air, then this one is breathing using accessory muscles. So this is a person that needs to be evacuated. And central cyanosis, which is basically the bluish discoloration of the lips and the tongue. Of course, with children, there are same signs, similar signs, but in children, you can see the nose flaring, the child starts breathing with the grunting sound. So these are children that shouldn't be at home. The rapid breathing is important to monitor. But this rapid breathing may or may not indicate worsening oxygen levels. So the clinical signs are not reliable indicators of hypoxia. Ideally, we should be using a pulse oximeter. I have encouraged some patients that can afford a handheld pulse oximeter or a fingertip pulse oximeter to actually have it at home, such that when you're a COVID patient at home under home-based care, you regularly take your pulse oximetry and monitor that. But this definitely does not cut out for the majority of Ugandans. Not everybody can afford a 50 or 100,000 to buy a pulse oximeter. So these are the ones that really are using signs. Someone having issues with breathing, someone worsening in terms of confusion, that may be a sign that their oxygen levels are actually going down. So this is a patient that needs to be taken away. But any patient, if you are monitoring yourself and you're at home, if your oxygen saturation goes below 92, this patient needs to be evacuated so that they can be supported. Their respiratory system can be supported with oxygen. We'll discourage oxygen support at home because not everybody, oxygen is a drug and it is titrated. In higher doses, it will have harmful effects. In low doses, it will not achieve its effect. So not everybody may have the capacity to, work around these numbers and see how to respond. I have a patient who was discharged from hospital at 86%. They went home because this particular facility needed space, and they told them to buy a cylinder of oxygen. They struggled, found one, and while at home, they managed to get one and put the patient on 1 liter of oxygen. And it ran for about 2 days. And when they called me up, one of the colleagues of theirs is a friend of a doctor, called me up and asked me why the oxygen was not going up. The oxygen was at 89 from 86 discharge. And later on, when I asked many questions, I realized that they had put the patient on 1 liter. So this is a drug that you titrate based on need, and then you act accordingly. So we discourage the use of oxygen at home. Patients with COVID-19 may actually look well, but severely hypoxemic, having very low tensions of oxygen in the blood, which we call happy hypoxia. So it's something that you need to watch out for. So the mild disease is what the asymptomatic and mild disease is what we recommend for home-based care. How do patients with mild disease present? They are going to present with non-specific symptoms. We discussed these ones already. But rarely they may also show up with diarrhea, nausea, and vomiting. So if you have this patient at home and you have been accorded home-based care, what do you do? If it is an adult or a child, more than 12 years of age, it is barely supportive. Most of the treatments that we have for COVID-19 are really supportive medications. We do not have any definitive treatment. We know that in the pathophysiology, there's a lot of inflammation. So, and most of the complications may arise because of inflammation. So majority of the treatments are targeted towards really making inflammation quite minimal. But largely, there is no magic bullet. We don't have a drug that is going to stop the virus from growing. But early interventions with providing the body an opportunity to defend itself, minimizing the inflammatory response that doesn't really get out of hand, has proved very, very fruitful for interventions against COVID-19. So somebody has a fever, they may require something to lower the drug, and here to lower the fever, and here we recommend paracetamol. We also promote zinc. Zinc is very important in anti-inflammatory activities. So for 14 days, somebody can take 20 milligrams of zinc every day. And vitamin D lately. We really want to give vitamin D to patients who have at least unestablished, have some evidence of deficiency, but this does not necessarily fall everywhere. We may not find a clinician that can assess you to determine whether you have symptoms of vitamin D deficiency, or you may not even perform the lab tests. Besides, it's not readily available everywhere. So vitamin D, this should be 1,200 international units, not milligrams, for 1 month for those with demonstrated deficiency. But it is a safe drug because it's anti-inflammatory. So for those that have nasal congestion and have a cough, whether it's dry or it's a wet cough, if it's a wet one, or if we can give nasal decongestants and mucolytics. For distressing coughs, we can give over-the-counter antitussives, those that suppress the cough reflex. And then we have products that are natural that usually contain the cough, dextromethorphan, and ambroxol, which is a syrup that we've used a lot in managing patients with these coughs. The inhaler that asthmatics have been using for their attacks can also be borrowed here for patients who really need to use them. Not everybody that has shortness of breath should use an inhaler. And this should be guided with a healthcare worker prescribing it and telling you how many puffs you should be using in such a situation. For children, similar story. We have syrup, paracetamol, zinc, and vitamin D. Lately, we have taken vitamin C out of the picture. I think majority of you may have noticed that because we are encouraging you to get the vitamin C from, the natural sources of vitamin C, like fruits, lemons, mangoes, oranges, and all this. Now, we noticed that vitamin C was also being abused. Everybody was taking what they wanted to take. People were coming in with side effects of lots of vitamin C, and because they were also taking that with steroids, they ended up developing gastritis, and all these complications that we could potentially avoid if we were to limit ourselves to the natural sources of vitamin C. So the monitoring of the danger signs is continuous at home. Like we've mentioned before, when you're home, you're getting those remedies, but make sure you also monitor for the danger signs, like we mentioned before. Now, household members. The house has more people than just the patient. Every household member is supposed to wear a face mask, but particularly that one that is taking care of the patient should wear a face mask, gloves, when taking care of the patient. Now, the gowns may not be available in the home, but in some home-based care institutions, you know that there are some people who cannot take care of themselves at home. And one of the contraindications actually of not taking care of you at home is if you are not accepted at home. If your wife is sick and you're worried that she will infect everybody, if your husband is sick and you're worried that he will infect everybody, and you're not comfortable taking care of him or her at home, it is advisable that this particular person is admitted in a non-traditional facility that can provide home-based care. And this has happened many times. So there are so many places that can provide home-based care in our setting. So wear eye protection, wash your hands at least 20 seconds after all contact, and use alcohol-based, hand-based sanitizer if water and soap are not available. Do not share personal items with the patient. Towels, dishes, utensils, and these should be cleaned separately. So do not mix patient's laundry with the rest of the household laundry, and if possible, the patient could wash their laundry, but if it is the caregiver, you should wait at least 2 days before washing or doing the linen. Avoid shaking dirty laundry around you. And then if you have, of course, this is for people that are high-end, setting machines to highest temperature as possible, but we usually expose the laundry to the sun to dry under the sun before use. Make sure that you frequently wash laundry and high-touch surfaces frequently. Wear disposable gloves while handling dirty laundry, and important to restrict contact to minimum number of caregivers. We recommend one caregiver as opposed to having everybody going in to see the patient and providing care. So the caregiver that is selected should be an adult, healthy, and this is one. So we know that we have one high-risk contact in the family as opposed to having everybody as a high-risk contact. So these treatments I have alluded to, but one thing that I want to mention from this slide is in the middle section. If oxygen levels are normal, that is 92% or more, this patient has a fever, you can manage that with paracetamol, you need to stay hydrated. You could also use the inhaled steroid that we are talking about. But one thing that has improved oxygen saturation in patients that are having COVID-19 is that lying in that position where you lie down on your stomach and you improve how much air, you increase how much air actually gets to access the blood tissues or the tissues that exchange air between the lungs and the blood. So this prone position, we call it a prone position, it improves lung oxygenation. And even when you're under home-based care, we recommend that for most of the time, if you feel short of breath, you can actually lie down like this, and this is going to definitely improve your oxygenation. But it is important that a COVID-19 patient gets to consult a doctor in case, or a healthcare worker in case anything changes while they are home. So check your oxygen, make sure everybody wears a mask. In this picture, they have even put a mask on the little baby, but we know that masks may not be very that encouraged for babies who are under 5 years of age. Open windows, make sure the home is aerated, isolate yourself if in one room if possible, stay hydrated, take at least 8 glasses of water in 24 hours. Oxygen use at home is discouraged. So you realize that if your oxygen levels are less than 92%, you will need to have support of oxygen. You may need to have the intervention of oxygen. Now, this should not be done at home for many reasons that I have mentioned. Dexamethasone or steroids at home, we try to stay away from steroids. Dr. Kirenga will tell you when his time comes for answering questions that steroids are reserved for patients that are going to have severe disease. Patients that need oxygen support are the ones that actually benefit from steroids. Otherwise, you may actually do harm to a patient who is stable, is having normal saturation, and you give them steroids. The steroid of choice in managing COVID-19 patients has been dexamethasone. And so many people have actually bought it over the counter. People have loads and loads of steroids in their home, loads and loads of dexamethasone. Please let us stay away from steroids. With all the many complications that steroids can cause, they can actually be more detrimental in COVID-19 than helpful if you give the patient who is still mild disease steroids. So now we get to the discharge. How do we discharge patients? It's interesting to call it a discharge because discharges are in hospital, but you could comfortably call it a de-isolation. Asymptomatic patients can actually be de-isolated if they have completed 10 days from the date of their initial COVID-19 positive test. So we believe that they are not infectious 10 days down the road after they tested. So if you were asymptomatic, you can actually be discharged 10 days from the time that you had a positive test. But if you had mild symptoms, then we look at the time of onset of disease. So if you had mild disease, you have to have at least 10 days from the day the symptoms started, and you have had no fever for at least 24 hours. Or if you've had a fever, or the fever should actually not be controlled by paracetamol. If your fever has been controlled by paracetamol for more than 24 hours, 10 days thereafter, then you are still not fit for discharge. The fever should not be controlled by fever drugs. WHO recommends a minimum of 13 days, 10 days after symptom onset, plus 3 days additional days without symptoms. So on average, that's why you see, we say we are going to isolate for 10 to 14 days for patients. Now, we do not perform a test at discharge or de-isolation from home-based care. However, there are situations where tests are demanded. For example, employers are demanding that when employees return, we should have a negative COVID test. So in that situation, the employers have need to be talked to, because there are some patients who have stayed positive for close to a month, and we don't know what that means, whether they don't get their salary for that month or we don't know. But the employers need to appreciate that there are some patients that may stay positive. So for the sake of infectivity, we say that really someone is non-infectious. So we stay away from testing unless really you have to. When patients are under home-based care, they're actually isolated. And isolation in the ward is basically keeping you away from the people that you're supposed to be with, the things that you're supposed to be doing. No, you're not going to the market, you're not going anywhere, you're home for those 10 to 14 days. So they develop a lot of stress and anxiety. So clearly we need to support the mental health while these people are at home. So we call on the psychosocial support teams that are usually provided by the VHTs in some settings, but the healthcare worker can also provide this. Now, with this happening in a home, the stress may not necessarily be on the patient, but it will definitely go all the way to the other people, the children, other people that are. I have had a situation like this myself, and I know what it means. The home becomes a mental health unit. You basically admit everyone. So it's tough, but you need to have, you need to seek support, online support groups, distress lines. The Ministry of Health has a good psychosocial team, but even the healthcare provider should be able to provide this. There is no need to panic when we are under home-based care. I think Lois clearly spoke to this. Panic is a very bad place to be when you have been diagnosed to have COVID-19, whether you are in a hospital or under home-based care. So engage yourself in intentional unplugging, relaxation techniques, balance diet, good hydration, sleep well, have enough hours of sleep, at least 8 hours. This should help you relax a bit. And most importantly, avoid substances of abuse, alcohol, smoking, and medication overdose. Now, in the implementation or rolling out of home-based care, we've actually faced a couple of challenges which are not necessarily new to all of us, but I wanted to highlight them here. That we do have poor health-seeking behavior that is causing delay in seeking care. The patients we are receiving at the moment are actually very sick patients, and we think this is because they're delaying to seek care. When you're home, you've taken the test, and these days people are taking tests on their own. They do not seek care from health facilities, and they stay home without knowing how to monitor and how to be evacuated. This is dangerous. So let's try to avoid this. Lack of efficient national ambulance and emergency care systems have also let us down. We have many patients that have tried to call and have struggled with being evacuated with the national system. Despite the challenges, the emergency system has actually set up a dashboard that is monitoring all the ambulances, at least within the Greater Kampala Metropolitan. There's a system that we have set up where all ambulances are being monitored. So now there is no room for an ambulance to say that they're not around when they're actually being tracked. So the system is improving. The referral system from one health facility to another has been a challenge. Even under home-based care, if a certain private facility was taking care of a patient at home and they see that they can't handle this patient in their hospital, they still struggle keeping the patient at home, despite their knowledge that the patient could become critical and they are unable to manage the patient. Irrational use of medications, antibiotics, steroids, dexamethasone, like we discussed. You'll notice that I have said nothing about azithromycin. In patients that are asymptomatic or have mild disease, I have said nothing about what? About antibiotic use. So we tend to stay away from antibiotics, unless the healthcare worker is the one who has recommended that you take an antibiotic. Don't use oxygen. Herbal medication use. We've had so many herbs that are being used. Now, when you're using a herb under home-based care, please make sure that this does not stop you from using what the doctors have recommended. I can't tell you that this is how much herbal medication you can use because I have no experience with that. But we know that some people have actually registered benefits in some of the medications that they use, but I cannot tell you that it is this one and that one. However, please note that these can turn out to be dangerous at a certain point. To this end, I also want to speak about steaming. I think we've also had a lot of people ask questions about steaming. I don't have a prescription that I can write for steaming. I can't say go steam 3 times a day, steam with water at these temperatures, add this and that and that. It is difficult as a professional, but we've seen people that have steamed and have actually suffered consequences. Their airways have dried up, they have burnt while they're steaming, and other things that can happen there within. People have reacted and have developed shortness of breath because the herbs they are adding to the water that they are steaming. Some of them actually cause constriction of the airway. So as you steam, may it be a steaming that is actually not torturous to you. We know steaming has been around for a very long time. For people who have nasal congestion, they can steam and the airway opens up. It's a physiological response once you break down this for COVID-19. And then of course the vaccination hesitancy, people are hesitant to get vaccinated, which is a challenge. So I want to end with this slide to just show you that this should have been the best pathway for evacuation. In the event that you're home, you need to inform your caretaker upon identifying a new or worsening symptom. Then the caretaker alerts the VHT or local leader, who then informs the health facility in charge. The health facility will immediately contact the RDC, where the system of RDC is working at DHO, DSFP, or the response team at the facility. And subsequent to that, the EMS is going to, EMS stands for Emergency Medical Systems or Services. So these have a toll-free line that the RRT is going to activate, and then they mobilize and allocate an ambulance that is going to evacuate you, and subsequently you're going to find yourself at a COVID-19 treatment. Now the challenges that are happening at the moment, right now we are fine, the numbers are down, but when we were at the peak, so people would visit treatment units and they are told that there are no beds, and they are bounced from one hospital to another. And this causes problems with some people actually losing their lives in the process. But this is because we've not activated the system that is supposed to activate, that's supposed to be activated, because they know where bed space is in the different facilities that are actually offering care. So Elizabeth, I think I will acknowledge MOH, the case management pillar, the social protection pillar, and the scientific advisory committee, and end it here.
Thank you so much, Dr. Ivan Kimuli, that has messages in the chat where people are noting that this has been very sorry, I got muted. Okay, the host keeps muting me. Okay. I should be okay now. So as just saying, thank you for that. It has been very informative and beneficial for all of us. We are going to try and take the questions through the chat. Often when we ask the questions verbally, we talk a lot, and we find that we are not able to take a lot of questions. And yet, as much as possible, we would like to take all the questions. I got cut off a bit in the process of this. So I'll request David
How
and
is someone
Angela,
supposed to submit?
for questions that I don't mention, please post them again on the chat or just have them by you so that we can be able to have them answered. So I'll begin with some of the initial questions. Before that, I want to say we've had lots of comments in the chat and suggestions, which we agree with, issues about the fact that we need to be concerned about street children who also need attention, the fact that we need to have isolation centers at some of the sub-counties, particularly where the housing conditions do not allow for isolation. So we've taken note of the suggestions that you have made. Thank you so much. There are also questions that have been answered in the course of the presentation, like someone asking if flu and an itchy cough, an itchy throat and flu could be a sign of COVID. Steaming, so Dr. Kimuli was responding to some of those questions, and so we may not ask them again, and you're welcome to put them in the chat again, which will show us that you really want us to ask again. So some of the initial questions, Dr. Kimuli, someone was asking, can COVID progress suddenly and silently? You mentioned that a number of the patients we are getting come in late, and that could be a result of several reasons. But could it also be because the person had COVID, they didn't realize, and the first time they realize they're unwell, they're really doing badly? So can it progress in your body silently, such that by the time you go, it's late and yet you were not aware of it? That is one question. And then someone was asking, how long does it take for you to progress from being asymptomatic to mild, moderate, severe, or critical? And I'll link that to another question where someone was asking, how long does the infection take in the body? Can it take a month and you have COVID and you're asymptomatic? But also, when does it become safe for me to relate with other people, for married couples, and you're practicing this isolation? After how long is it safe for us to get back to the sexual relationships after someone has been ill? So that is really the question about, if I'm asymptomatic and I wait 2 weeks, am I safe? Should I be sure after a month that this is not progressing silently? And then there was a question about whether you should when should you do a PCR test and when should you do an antigen test, because we know that there are different types of tests. Then someone was also asking about steroids. So steroids, how fatal are they? What are the side effects? Which ones are safe to be used? How fatal are steroids? What are the side effects? Which ones are safe? And then when should you do a PCR test? When should you do an antigen test? Then generally issues of when do you stop posing a risk, when do you stop shedding the virus? So we'll first take those ones. Thank you, Ivan.
Okay, so thank you very much, Elizabeth. I don't know if Dr. Kirenga would be happy to take some of these questions, so that yes, Dr. Kirenga is on the call. I think we will walk through this with him, unless you want to invite him later. Dr. Elizabeth.
Okay, thank you. I got off at some point, so I wasn't sure whether Dr. Kirenga had joined or not. So Dr. Kirenga, you're very welcome. So I'll pass the next set of questions on to Dr. Kirenga. So you can start off with those ones and I'll pass on the next ones to him. And if there are any, it would be better for him to answer, that's also okay.
Okay. So I hope I picked all the questions, but I know as we respond to this question, we shall definitely touch on each and every question. So one of the questions that seems to be coming up is the persons that present late, would it be that the COVID was worsening in them? Yes, we are different individuals. So like we said, majority of the patients are going to stay asymptomatic. Over 80% of the patients are going to stay asymptomatic. But the few that are going to develop, or mild disease, but the few that are going to develop disease are going to present in varied ways. Those that will have mild symptoms, those that will have moderate symptoms and the like. So it's possible, and there are categories of progression that have been identified, the fast progressors and the slow progressors. So if you're a fast progressor, you're definitely going to come in with your symptoms early enough. And you are probably also going to present with maybe more disease at the time. But it also depends on how well the virus found your immune system. How prepared was your body before it got exposed to the virus? So for persons that do not have what I would call baseline defenses optimal, these are going to progress faster and probably develop more disease compared to somebody who had more reserves. By more reserves, I'm not talking about someone who's obese, but I'm just talking about someone whose immunity is intact. They are not abusing alcohol. They are not on any immunosuppressive drugs. They have nothing really battering their protection against some of these viruses. So yes, you could end up with symptoms, and then but somebody who is fairly strong and immune may take some time before the symptoms show up. So in that person, the symptoms could actually show up towards the tail end of the incubation period. And if indeed they had a high volume of exposure to the virus, maybe they're actually going to develop severe disease. I may have missed a few questions. How long does the infection take in the body? So we talked about the incubation. We talked about the incubation period. It is 2 to 14 days from the time you get exposed to the virus, or from the time you get infected, and the time you develop symptoms. So 2 to 14 days. So we think that after 14 days, you have probably gone past the time that you develop symptoms. However, the virus could stay lingering on. And if you develop symptoms, they would probably be coming down by that time. Day 14 to day 21, the symptoms are really coming down. And you may actually have little virus that you can shed, if any, after 7 to 10 days of having been infected and developing symptoms. So the infection could linger on a little longer, but the infectious nature of the infection becomes less aggressive as the days from symptom onset increase. If I'm asymptomatic, am I safe after 2 weeks? Yes, it is assumed that your chances of infecting somebody else are first of all very few, if any, after 2 weeks, if you have been asymptomatic. But by being safe, I don't know what you meant. Was the meaning that am I not going to develop disease? Because if you've not developed symptoms after 2 weeks, it's unlikely that you're going to develop symptoms. But in terms of transmission, considering this is an infectious disease, as public health specialists, you'd be concerned that is this person safe to mix with or to mingle with other people? Yes, you could be safe, but you need to continue observing the SOPs. Continue masking, continue the social distancing, continue the sanitizing. You cannot say that you're completely fine, but the risk of transmission is much, much reduced if indeed there is. When is it safe for me to relate with my wife or with my husband? I am assuming that was the question. You know, some of these things, some of these words are difficult. The Bible says my wife and my husband. But with that said, we have no guidance that has been provided that it's okay for you to relate after 1 week or 2 weeks. In that situation, it is important that you actually perform a test if you had the capacity to actually perform the test, so that you know that you are going to be close to your wife, close to your husband. This is going to be 0 distance. It's not going to be 2 meters. So it's safer that you actually perform a test. So if both of you are negative, then that is a good time for you to relate. But if you're not going to perform a test, I cannot give any guidance. Maybe someone else who has this experience could share. If I'm asymptomatic, when should you have a PCR and when should you have a rapid diagnostic test? One of the things that we've been discussing in terms of diagnostics is the PCR does become very popular and available in patients who do not have symptoms. So if you do not have a test, if you develop symptoms suggestive of an antigen test, but if you've just been exposed, if you're a high-risk contact, you are symptomatic, or you are traveling and you need to get a COVID test, this is not the best test for you. Then you have to perform a PCR. So the antibody test is for symptomatic people, symptomatic contacts and alerts, but the antigen, the PCR is the one that we can perform, of course, both in symptomatic and asymptomatic patients. How fatal are steroids? I know Bruce will speak to this. Which ones are safe, which ones are not safe? Steroids, definitely, we've talked about all the various side effects that they could have. They could have side effects in the acute phase. They could have side effects in the chronic, after chronic exposure. So clearly, we should stay away from them. I don't want to go back into mentioning what the steroids would do, but I would encourage that any person that is going to take steroids, they should be prescribed by a healthcare worker. We should not stay on steroids for a long time, but also we've already mentioned that steroids can actually be detrimental. They can offset a phase in your infection that can make your recovery a little challenging compared to someone who actually needed them at the time that they got exposed to them. So for patients that need oxygen support, steroids will be beneficial, but for patients that do not need oxygen support, they may actually be detrimental. But they have lots of side effects, like you could have seen, increasing your susceptibility to infection, developing high blood pressure. They could cause some of the hormones some of the glands that produce hormones to stop producing them, and therefore developing insufficiency of the function, and many other things. So which ones are safe, which ones are not safe? All steroids can be unsafe if prescribed irrationally or if taken irrationally, and if the doses are not overseen by a healthcare worker. Let me get the microphone back to you. I don't think I've responded to everything, but most of the questions will be definitely tackled along the way.
Thank
Elizabeth,
you.
back to you.
Okay, thank you. Thank you very much, Dr. Ivan. So again, I want to thank Dr. Kirenga for joining us. We're informed that you were attending a meeting and might not be able to make it. We are pleased that you were able to make it. Dr. Kirenga is a physician with specialization in the respiratory area. He was one of the founders of the Lung Institute that deals and handles respiratory illnesses and complications. So we are particularly pleased to be able to have him here. So Dr. Kirenga, you're very welcome. So I will focus our discussion with you initially on some of the respiratory related questions and then some of the others as well. So someone was asking if they have asthma, should they be immunized? And then someone was asking also about treatment for clots. Should that be given routinely to people who have tested positive for COVID-19? And if someone suffered, has DVT, for instance, we know that COVID, the blood thickness and so on, is it safe for them to be vaccinated? After how long? Someone was asking if all breathing difficulties are related to COVID-19. I think we have cases where people have assumed this is COVID because they have respiratory issues, and it is not. Could you speak to that? Then the issue of oxygen dependency, if you can comment on that a bit. Someone was saying they have a patient, I think 77 years, who was discharged, has been on oxygen, and then usually his saturation is at about 90 to 95%, and then it drops down to 80. So should they get worried? But also, for how long should they continue with this oxygen saturation? Then there was someone who had got COVID and had nasal congestion about a month afterwards. So they're wondering if that is normal. So there's a question on nasal congestion, and that person is concerned. There's a question on oxygen dependency. A 70-year-old, 90 to 95% when they're on oxygen, then it drops down to 80. There's a question asking if all breathing difficulties are related to COVID-19. Treatment for clots, is it mandatory, or it's for certain people? And if you have something like DVT, how soon can you get your vaccination? If I have asthma, can I safely be immunized? So Dr. Bruce will start with those questions. Hello.
Hello, good afternoon.
Yes, good afternoon.
Yes, thank you very much for inviting me to be on this panel. And thank you, Ivan, for a wonderful presentation, giving all the details of the home-based care. So I will go direct to the questions. And the first one, if you have asthma and maybe any other chronic lung disease, should you be vaccinated? I think yes, there's no question about that. You should be vaccinated because you are even at a higher risk of getting severe disease. The other one is about medicine for clots. Should it be given to everyone? I think I've untouched this. We give medicine for clots to patients who have severe disease. We don't give it to patients who have mild to moderate disease. I will not go into the details because I see actually our time is up. Now, for people on DVT, should they get vaccinated? That's a very interesting question. The causes of DVT. DVT is development of clots in the large vessels, usually the vessels of the legs and the abdomen. Now, the mechanism why those clots come there differ from disease to disease. The thrombosis that we see in that have been associated with some vaccines is actually some form of an inflammatory reaction, which is, I guess some people here are medical workers, which is kind of related to what we used to call HEAT, or what we call HEAT, the heparin-induced thrombocytopenia. It's some autoimmune problem, which may not cross with the reasons which caused you to have the big DVT that you have. So you can take the vaccine, and of course, we monitor. Now, the patient who is dependent on oxygen, we have seen that phenomenon actually quite a bit in patients who have had severe disease. They recover, they move away from needing high flow oxygen, they go to low flow oxygen, 2 to 3 liters. Some of them even very low. We had a lady who needed only 1 liter of oxygen to move from 85 to 95. But should you take it away, she will go to 85. Now, we have discharged those patients on oxygen, maybe from concentrators, which are very safe. They are more safe. Maybe that's a discussion for another day. For home oxygen, it would be better that people use concentrators because the pressurized oxygen can actually can be dangerous in the homes. But we send them home on those concentrators. But for how long? I think this is the question this person is asking. What you should do, look at what happens to this patient when you take them off oxygen and it goes to 85. Because we should not treat the figure of oxygen, we need to treat the patient. What happens to them? Are they breathless? Are they gasping for breath? If they are not, most likely, these people, they have had lung damage. As you know, COVID lung damage is extensive. It has recovered and there is modeling of the lung. And probably this 85 is their new normal or new abnormal. So if they don't have any danger signs, you can actually take them off oxygen for several hours, especially during the day, but at night they can use oxygen. Now, long-term oxygen is actually not a new thing. Here at the Lung Institute and as pulmonologists, there are many people who are on oxygen, people with the COPD, interstitial lung disease, and for people who have been out there, you've found some patients with a small rucksack. You think this old man is trying to be very fancy, but actually there's a small oxygen tank in the back, and he's going on with his own life. So the key thing is to look at the danger signs. But probably you need to have this patient evaluated, get imaging, probably a CT scan, such that we can quantify the amount of damage on the lung. We counsel the patient, and we take the patient through what we call pulmonary rehabilitation, which is a physical treatment of chronic lung disease. Now, one of the things we deal with in pulmonary rehabilitation is telling patients that, look here, I used to have 100% lungs, now you have 40%. Do not expect to behave and work like someone who is 100%. If people walk from 100 meters in 10 minutes, don't think you are going to do that, but you can still walk 100 meters in 20 minutes and you'll get there and you'll be fine. Those are the specialist things that we take these patients. The one of nasal congestion, I think this is most likely an allergy, which could have been pre-existing before COVID, and they should get treatment for it. However, they should also get a medical examination, especially an ENT surgeon. There could be other things within that nose that should be dealt with. It is unlikely that this is due to COVID. So thank you very much. I think I have responded to the questions.
Okay, Thank you very much, Dr. Kirenga. Our time is past, but I know people have questions that really need answers. I'm begging you and Dr. Kimuli to stay with us maybe another 15 minutes if you can. Is that okay?
Yeah, that's fine.
Okay, thank you. So our participants, I said, would close at 2:30. If you had pressed and you need to go, that is fine. But I know sometimes when people post questions, they really have a number of issues that they want us to deal with. So I'll just do the last set of questions. I'll give a few to Dr. Kimuli, then I get back to Dr. Ivan, and then we close. So someone was saying we have heard about the Delta variant. So in the symptoms that you told us about, is there a difference between the presentation that we are seeing with patients coming in with the Delta variant compared to the variants that we had earlier on? So just the Delta variant and issues related to that. Then there was a question about pregnant mothers that was not very clear. It was just asking about data on pregnant mothers. But perhaps the person is interested in knowing, is it safe for a pregnant mother to get vaccinated? Someone also asked if they can breastfeed their babies and any other particular danger signs that pregnant women need to take care of. So any advice for pregnant mothers? And then someone was asking about why we still have azithromycin on the MOH home-based care manual. I remember you were mentioning that you did not emphasize azithromycin. Then there was someone who was asking about the role for Mentelucast or colchicine. So I think those are the ones I will I'll put to you, and then I'll pass on the others to Dr. Kirenga, and then we can close. So the Delta variant and any symptoms, differences in terms of the symptoms, then pregnant women, can they get vaccinated? Is it safe? Breastfeeding. Earlier on, people had also asked, when they see patients who get vaccinated and then they get very sick and they die, should they blame the vaccine? Could they have got COVID? So if you can speak to that as well, and then why we still have azithromycin. So yes, so over to you, Dr. Ivan.
Okay, thank you very much, Dr. Ekirapa. So the Delta variant is an interesting variant. We can speak about it or speak information related to it for a day. But one of the things that we have seen is that it has been very infectious. To us as public health specialists or people who are really concerned about mass infection, this is something that we have noted. Clearly, the symptoms have been observed to be more varied compared to what we saw at the beginning. In the first wave, the symptoms were typical, but we have largely seen symptoms that are relatively the same, but having more systematic or systemic involvement compared to what initially there was. So people can literally come in with anything. And one of the things I'm actually recommending to my patients is that when you come in, you should try to fix one of those essential investigations as a COVID-19 test. So we have many patients that go to the clinic, they're feeling weak, and all they do is a blood slide and a CBC and maybe a urinalysis. all these ones turn out negative, or if you are unlucky, I say unlucky because that is going to be chasing the wrong signal, you may find a slight rise in the white cell count, which may confuse you that this is probably a bacterial infection, and you treat as such. And people have also treated malaria for starters. But anybody that has negative tests, I really recommend, if you have a fever, a headache, please go ahead and perform a COVID-19 test. So the symptoms have really been systemic, but doesn't make them any different from the symptoms that were previously described. It's just that they are more pronounced at the moment. And we are seeing children actually presenting with more disease than we saw in the first wave. So that's where the Delta variant is taking us. Now, for pregnant mothers, can they get vaccinated? There is no contraindication for pregnant mothers, especially if the pregnancy is more than 3 months. We actually say that because pregnant mothers are having worse outcomes when infected with COVID-19, they are a good group that should not stay away from being vaccinated, especially so if someone is more than 3 months pregnant, because we know by then the chances of having problems with the baby inside are much less. So there is no contraindication. When we are signing that consent form, you realize they ask you whether you're pregnant, but after that question, they don't stop you from getting the vaccine. Can they breastfeed? A COVID-19 mother can actually breastfeed their child, and it's in our infant feeding guidelines, we recommend that breastfeeding and neonates that has been delivered should actually have contact with the mother for breast milk, that breastfeeding that is exclusive, at least for the first 6 months. What the difference is that you do not spend a lot of time with the child. After the child has breastfed, of course, the time that they're breastfeeding, you're observing all the SOPs. You are masked up. If you're in hospital, some hospitals have actually provided gowns for their mothers, but you should have masked up. You'd have had your hands washed with soap and water, and then you breastfeed the child. After breastfeeding the child is placed away from you until the next feed is available, is required. So we reduce the time of exposure of this child, but we also make sure that you yourself are masked and you are performing hand hygiene to the dot. So there's no contraindication to breastfeeding. Until now, we have no evidence of transmission through breast milk. So we cannot discourage breastfeeding for COVID-19 mothers. Why do we have azithromycin? So the new guidelines, the third edition, are recommending that with asymptomatic or pre-symptomatic or mild disease, people should not take azithromycin unless, of course, the chest symptoms are more than usual or would warrant a clinician to actually make the prescription of azithromycin. We are discouraging people from buying it on their own because anybody who has a headache is going to end up buying azithromycin because they think they have COVID-19. Anybody with muscle pains and things like that. But I think on a case-by-case basis, azithromycin can be prescribed by a clinician or a health worker, depending on whether they find that there's a need. The role of montelukast and colchicine, Bruce will also speak to this. He's one of the providers of care in the CTU, but colchicine is being studied and used elsewhere as it is anti-inflammatory. You remember I told you that largely the disease or the symptoms that we see from COVID-19 are really inflammatory symptoms. So all anti-inflammatories, there are many on the trial list that are being trialed in many places to see which one is going to produce a better outcome. So colchicine has been used. Our guidelines do not recommend colchicine yet, but we know that it's an anti-inflammatory that is being used in COVID patients elsewhere. Montelukast is a respiratory drug that we've used in patients that have asthma or allergic conditions, especially in the lungs. So this promotes the airway caliber to stay large, so that air can go in without too much trouble. So it's one of the drugs that you can say these are respiratory drugs. So it has also been used, but we don't have it in our guidelines. So we can't say, please go ahead and prescribe Montelukast on a large scale. Vaccination and then somebody dies. Is it because of COVID? Is it because of the vaccine? I think I guess there are some natural occurrences that happen. If you look at the number of patients that have been vaccinated worldwide, granted, we have different vaccines that have been given. We have Moderna in some places, we have AstraZeneca here, we have BioNTech somewhere. So we know that there are more people that have actually been vaccinated than bad outcomes that have emanated from these vaccinations. So it is difficult to say that really the vaccine is the one that has caused the mortality. And we have an AFI committee that addresses all these AFIs. As long as they have been reported, they pursue to the end what exactly happened when any significant or serious AFI occurs in the patients that have been vaccinated. So mortalities have been reported to the AFI committee, and they have been reviewed to see whether they are actually related to the vaccine. Unfortunately, I don't have access to that report, but there's a possibility that someone could actually be vaccinated and they get a bad outcome. But these are very rare events. So it's unlikely that every person that has died because of a vaccine, or rather after being vaccinated, they're dying because of the vaccine. But I guess we cannot rule out other conditions that a patient could have before they get to be vaccinated. We've seen patients come in with clots after being vaccinated, and they try to work out to see the possible relationship between the vaccine and this clot. But in close review, like Dr. Bruce tried to explain the pathophysiology of these clots, we actually find that these are patients who do not have these clots. We find that their platelet counts are actually normal. Granted, we don't do the platelet antibodies, but one of the key criterion is having a low platelet count below a certain amount. So with this, we actually find that someone had a clot, but it was not, most likely it was unrelated to the vaccine. I submit.
Okay, thank you. I had some issues there, unmuting. Thank you so much, Dr. Ivan. There's a question someone asked, which was attended to last time, but I've lost it. So I'll just focus on the ones that are here. So someone is asking about Covidex. This next set, Dr. Kirenga would like to direct them to you. We can't finish this call without commenting on Covidex. So people are asking about Covidex. How helpful is it? Are you able to speak to that? Then people are also asking about the pulse oximeter. How reliable is it for tracking oxygen saturation at home? The readings keep fluctuating. What is the right level? And how does it vary? You know, if you're an elderly person with some chronic illness, or just an elderly person. For children, those who are young, ill people, people would like a comment on the variations in the readings and what is acceptable and what is not. And then there's also a question about embolism. Someone is asking, can you develop pulmonary embolism after COVID-19 infection recovery? And they also wanted some clinical manifestations and advice. Then someone is asking, lack of sleep, is that a side effect of COVID-19? Is it a common thing that you see? Is it okay for them to take sleeping pills? And then lastly, we also wanted to ask you about why ICU costs are so high for COVID-19. We know that sometimes these costs are rightfully high. You know, sometimes you may find a number of reasons that may not be justifiable, but it's helpful for people to know what resources are needed in ICU, just in brief, that make the costs high. But also related to that, Dr. Kirenga, I wanted you to comment a bit. Sometimes you have a patient who is very ill. The doctors know this patient is not going to survive, but the doctors don't want to discourage you. So they're not directly going to tell you, stop paying your 5 million every night. Your patient is not going to survive. Such things are difficult to deal with when you're at that point. But we've seen you know, patients die with debts of 90 million, possibly father and mother gone, and the children left without, you know, money that could have helped them, and was all drained in hospital. So the question I'm putting to you is, what parameters can we see that could indicate to us that, you know, the prognosis here is very poor? And if you're not Bill Gates or someone like that, and money is not easy to come by, you need to really think between continuing to pay those bills. There are people who have an oxygen saturation level that is steadily decreasing. It's, you know, 60 today, 50 tomorrow, 40, they're in ICU, the family is paying, you know, 8 million every day and selling everything they have. What parameters can indicate to us that the prognosis is not so good, and we just need to accept that rather than finish all the money we have and end up losing the people who are precious to us, but also end up leaving, particularly children, homeless, with nothing for them to fall back on. So the question that was answered last time was asking whether if you miss your COVID-19 vaccination on the due date, you can still take it. And last time, Professor Biachika commented that you can still take it even after you have missed the due date. The current literature was not particularly indicating a limit on how late you can take that. So just to summarize the questions again for you: lack of sleep, is that a known side effect? Should they take sleeping pills? COVID-X, comment on that. Pulmonary embolism, you know, could it follow? The pulse oximeter, how reliable reading with different chronic, you know, the young, and so, and then 19, the ICU was so high. But what parameters can indicate to us that, you know, our patient is not doing so well, and you might, you know, lose them, just so that we begin to prepare ourselves and also don't spend all the money we have in vain, so to speak, despite the love and care. So we'll end with that round of questions. Dr. Kirenga, over to you. Dr. Kirenga, I hope you're still with us. if you're having problems unmuting, Davidson, I hope you can attend to that. I had some problems unmuting myself before.
Okay, thank you. I definitely, the host had stopped me from unmuting. Thank you for those questions. I don't know which ones. I will go with the simple ones quick. The first one of COVID-19. This is a very difficult question. We don't have clinical data to show the efficacy of COVID-19, and there are efforts to make sure that these clinical trials are conducted. I was actually supposed to be in one of those meetings, but I thought, Professor is enough, I can be here. We don't have to both be the other side. Until those clinical studies are concluded, it is very difficult for modern medical doctors to comment. But I want to put a disclaimer because there is a lot of effort with our colleagues, the biochemists, to innovate the local products. This is completely fine. For me as a clinical scientist, if you bring me a product, you show me preclinical studies, which now it is believed that because these are products being used in the community, those are completed. You show me some safety studies. All we have to do is to randomize and consider these products, and we will tell if the products work or not. And that will solve a lot of problems. Yeah, allow me to stop there on COVID-19. The pulse oximeter. Of course, these pulse oximeters we are getting from the pharmacies, these are home use machines. They are not as robust as the machines you see we have in the hospital. So they are performing to the extent they can perform. However, there are things which can make them not work very well. Some of them operate on cells. The cells could be down. Some of them need calibration. Calibration is you bring this little machine to a standard machine and calibrate it and see that it's still measuring what it should measure. 3 is that there are things which interfere with its sensitivity. One of them is nail polish. So if you have nail polish, you can remove it and check again. You may improve the sensitivity of the oximeter. Others, of course, include application of the oximeter itself. The way the oximeter works is by picking the color of your blood through your skin and using a nomogram to give you an answer. So if you don't apply it where there is blood flow, you expect that it is going to give fluctuating results. But it's a good machine, which is good in monitoring, and people should use it to tell when oxygen could be needed. But they need also to add the parameters that Ivan told you, what we call the danger respiratory signs, in addition to what you are seeing on the pulse oximeter. About pulmonary embolism after recovery, actually, contrary to what is widely known, the thrombosis in COVID is not in the big pulmonary vessels. Most of it is what we call in situ thrombosis. It is in small vessels. And this in situ thrombosis causes silent hypoxia that is seen in the COVID patients. However, when people have been in the hospital for a long time, especially people have been significantly sick, they now bring in other things which can make them make clots, including immobility, including some of the drugs that we have been using to treat them. So now in the post-recovery phase, people could develop clots in the large vessels. Now someone wants the clinical features, of course that's a whole class. For MBCHB, we may not finish them, but for the public, I want to tell them the few. One of them is a heavy chest, the heart which is racing, extreme tiredness, sudden collapse. Those are some of the key features that could tell that someone could be developing a big clot. And usually these are of sudden onset. Lack of sleep, I think one of the key things is what we call the post-intensive care syndrome, especially for people who have been very sick. You know, when you are in a hospital, especially the intensive care, life is 24 hours. People are being brought, people are being discharged, people are being taken out. The machines are blazing the whole night. People are working. So if you are in there for 2 weeks, it's a very big life event. So these patients, if they have problems, lack of sleep, anxiety, the psychiatrist could give, they should seek a psychiatric care and they can be treated. But the post-ICU neuropsychiatric syndrome is very big and can have a big impact on people. I'll leave that at that. I will end. I want to end with this one, which I can't answer. But let me try to attempt the issue of what you are asking. Are there patients who are too sick that we say let's withdraw care and start de-escalating? This in critical illness, this happens. But I want to first tell you the story of COVID-19. Actually, COVID-19 disease is a very bad disease. People have been normal. The people we are talking with on Friday, they were completely normal, as good as you, like you see me here. Develop a little cough on Saturday, the cough gets worse on Sunday. By Monday, you feel you can't walk normally. They check your oxygen, it's 85. They say, no, let's just give you some oxygen. After another few hours, you now need more oxygen, and another few hours, you need more oxygen. They say, no, we'll take you to the ICU, give you some machines to support you, then the oxygen goes down. And all these things are happening in a matter of hours, by the way. And before you know, someone is on a ventilator. These are actually normal patients. So withdrawal of care in patients who are sick like this, it's like someone has been knocked by a border. This is actually the COVID death. Withdrawal of care in these patients is very difficult for us when we are treating these patients. However, in people who are chronically sick, who are ventilator, no, the word that people use is not good. They are ventilator dependent for several weeks. There are parameters that we use to say this patient, even if we keep the machine breathing for this patient, the recovery is not going to happen. Now, when that happens, the decision to withdraw care is not a single physician decision. Usually you discuss with a physician of the same qualification, and if they agree with you that this is a futile endeavor, then you bring this discussion to the management of the hospital. And then you involve the family and you withdraw care. So Chair, for COVID patients, it is become very difficult. We keep hoping that this person who was talking yesterday is going to get to become better and better. Now, a recent study which has been done, I know we don't have time, has actually discovered that most of these COVID patients develop cardiovascular events, 42% of them, which cause sudden death. So even when we have these patients on the ventilator, They actually look stable by the parameters we are looking at. And then just in a few hours, they decompensate, they develop all these chaotic heart rhythms and they die. So it may be difficult in that case. I hope that helps. And people appreciate that this is not the normal ventilator-dependent patients that we can have meetings to decide. The patient is actually not even giving you meeting to decide. You will come at 2 p.m., find they are oxygenating very well, blood pressure is holding very well, they are doing well on the ventilator, and then you come back the following day, and the patient has died. Okay, and lastly, why are ICU costs very high? Yeah, this is a very tricky question, but I will attempt to comment on it. World over and everywhere, whether in government or private facilities, ICU care is expensive. There's no question about that. However, the colleagues who run the private COVID care need to note down a couple of facts. That one, this COVID thing is a disaster. There's no question about that. And the number of patients accumulate at a very high speed. So when you sit in a private hospital, you need to realize that actually that all the patients who are coming to you, they are not as private as you think. They are coming because they are desperate. They have nowhere to go. Someone is dying, okay? Or they are coming because they know what COVID can do. Someone has told them, if you go to so-and-so's hospital, you will survive. It's not like they are private. So through this discussion, I think the hospitals need to set up packages or tracks. The general COVID care. Yes, you're in a private hospital, but you have people who are general. And then you have the real private patients, your patients who are coming. The other thing which could be done is to practice evidence-based medicine to reduce the costs. That give only the medicines which are known to work. Do not be put under pressure to become a star. Give all sorts of treatments which come in your head and you think you are going to save someone when actually you are just increasing the bill. Stick to what has been shown to be evidence-based and do not escalate treatments which are not known to work. This has actually been one of the biggest drivers of the high costs. And lastly, what I will comment on this is maybe second last, is that COVID being a disaster, the people who are providing private care should actually not be seen as people providing private care. They are actually people providing a hand to government. So there are things where government can help these people to bring down the costs. For example, oxygen, okay? That's one of them. Government can actually provide oxygen because it's one of the biggest cost areas. I have also learned when this issue came up that actually some of these ICUs do not have ventilators of themselves. They go and rent a ventilator from someone somewhere who is making maybe 500,000 per day. They bring a ventilator. So for you, when you go to this hospital, you look at it as it's the one making the money. But there is someone who is renting a ventilator. So government could make ventilators which are available and are not being used, or even new ones, and advance to these people who are providing a hand. And now I come to my last comment on this, that the private providers must realize that this is a disaster and there is no need to make a lot of profit from a disaster. You cannot profit from a disaster. And this should be the background. So when costs and markups are being put on what has been provided, you keep it to the minimum. Put the most basic markup, because like I told you at the beginning, these people are coming to you, they are not private as you think. They are only struggling to find where their patients can survive. So, Chair, thank you very much. These have been very good questions. And thank you for the opportunity to discuss this. Over.
Okay, so thank you very much, Dr. Bruce Kirenga. So once again, I would like to particularly thank our panelists. Thank you, Madam Lois Kyoma, for being with us and sharing your experiences with us. Thank you, Dr. Ivan. Thank you, Dr. Bruce. This has been very informative. For those who've been able to join, thank you so much for coming. We shall share the slides with you. So Dr. Ivan, if you could please share the presentation, we shall share the slides with you. And for the rest of us, let's take these messages with us. Let's also advise other people we may meet. It's impossible to summarize all the important information, but I just want to say, remember that when you test and you're positive, you need to initially seek medical evaluation. Don't just begin to self-medicate yourself. Also be careful about the medication you're given. We've heard about how dexamethasone, anticoagulants should not be routinely given to everybody. So take care of that. You may go to a provider who is not yet aware of this, and they may do otherwise. So think about that, and also stick to the isolation information that we're being given when you're caring for patients at home, so that we ensure that those in our surroundings are safe. So I would like to thank Angela Davidson, who helped to organize this. And thank you everybody for coming and staying with us. Again, apologies for going over our time, but these are difficult periods, and I thought your questions are important, and you're here because you want to have them answered. So thank you so much. Have a good afternoon, and thank you again, our panelists, and bye-bye, everybody.
Thank you, Dr. Ekirapa. Let's see the video.